Introduction to Health Literacy. This is the first in a series of 2 webinars to be developed under the project Person-Centered Care funded by the National Diabetes Service Scheme. This project is managed by our project officer, Tony Rice, who is with us today. The whole webinar is designed for those involved in direct patient-centered care or developing resources for people with diabetes, and will be presented by Ambreen Mazar, Project Officer, Clinical Specialist at the Center for Cultural, Ethnicity and Health in Victoria. Ambreen has a bachelor and master degree in psychology and has worked in community mental health for more than 12 years with a special focus on psychological trauma. She has a strong background in human rights and its application both in Australia and internationally. For the last 4 years, she has worked directly with migrants and refugee community in Melbourne, delivering services to facilitate settlements and increase community participation. Ambreen is an experienced trainer and has developed and delivered numerous training modules for the community and service providers on a range of issues, including leadership, health literacy, cultural competence in counseling, and family violence. So before I pass the mic to Ambreen, please note that these sections will be recorded, and the recording will be available on the webinar webpage after this section. During the presentation, please send us any questions you have through the chat function, and Ambreen will address them during the Q&A. Now, with no further delay, please join me to welcome Ambreen.
Hi, everybody. Thank you very much, V, for the introduction. I have to say, I haven't, this is the first time that I am sort of doing giving a webinar, so it's very different when you're actually in a training, actually getting reactions from people, but hopefully all will go okay. All right, so I think we're good to go. Great. So just to tell you, so welcome to the Introduction to Health Literacy webinar. This is really a snapshot of, I guess, talking a bit about, starting the conversation about health literacy. So before we start with that, I just wanted to tell you a bit about the organization, the Center for Culture, Ethnicity and Health. And some of you may be familiar with it, and for those of you that aren't, just sort of give you a brief overview of the kind of work that we do. So at CEH, we basically assist health and community services to improve their services to refugee and migrant clients and communities. And we do this through a number of ways. So one of the ways that we do this through is training, obviously. And we have a series of calendar trainings that you can access on our website that we run regularly at the center. However, we also sort of take trainings on requests that are requested by organizations to build their institutional capacity. We also conduct a lot of research and gather information. We have a full-time librarian and a well-stocked library. I would really encourage you to visit our website and look at, you can access our library material from there. You can sort of Google in whatever you're looking for, and material will come up that's downloadable and printable. You can also become a member and come and visit our library for any information related to culture and health. We also develop a number of resources for organizations and do social marketing work. This is also a huge part of what CEH does. We also work specifically at doing project management for organizations who want to sort of roll out specific health projects and health promotion projects. We also do direct community education and support with specific communities in Victoria, and this is a very important part of what we do, because we sort of want to approach everything in a sort of holistic way. And so the challenges on the ground definitely inform the kind of work that we do. So if you have any questions about CEH, you can, of course, send that to V, and I can answer that later. All right, so just to give you a bit of an overview of how we're going to spend the next 40, 50 minutes, today we really just want to provide an introduction to health literacy principles. This is a very small snapshot. We actually do health literacy training, and we also have a health literacy course that runs over 8 months. We have an intensive training as well that we conduct at CEH. So this is really sort of less than an hour, kind of giving you, the basic information, and provide a brief overview of points to consider during consultations. So how does this actually affect your practice and what you can do in the clinical encounter, and then provide some links to health literacy information and resources later on. Great. So let's start off beginning with what is health literacy. Now, if we were actually in a face-to-face training, I would sort of elicit answers from you. However, this is obviously that can't happen at this stage, but I did want to share with you the range of definitions of health literacy over the next 2 slides. And while I wanted you to have this information, this is certainly not to overwhelm you and confuse you. There's a lot of definitions on here, but I just really wanted to highlight that it really depends on which sort of area of health you are working in, and based on that, the definition will be slightly different. There are many phases of health literacy, depending on where you are and what you're working, what your specific role is. But for our interest today, you can obviously have a look at that later, but for our interest today, for us, we're going to use Don Nutbeam's definition, who is a public health expert in the UK, and he says that health literacy is the personal, cognitive, and social skills which determine the ability of individuals to gain access to, understand, and use information to promote and maintain good health. Now, it seems quite simple. So health literacy is really about how people access information, understand that information, and then are able to use that information. Health literacy is now getting a huge push from the government and the state level. There has been a national statement on health literacy that was released. Every health minister in the country has signed on to this statement, which is a huge thing. It is now currently being embedded into, health literacy is now being embedded into accreditation standards. And basically what it's looking at is looking at health literacy on 3 different levels. And as you can see, the first statement is having consumers who are partners in the process of health and healthcare for safe and high quality care. So that's, including consumers, carers, community members involved, getting them involved in the process of managing their own health. Health literacy also plays a role in enabling effective partnerships, as well as, making sure that the health system and that healthcare organizations also have this embedded into their system. And then the last paragraph will show you that when these conditions exist, there is the potential to not only improve the quality and safety of healthcare, but also reduce health disparities and increase equity. So these are basically your outcomes of health literacy. The Australian Commission on Quality and Safety in Healthcare has also released an excellent document, a policy document, that has outlined the important aspects of health literacy. And in it, the core concepts are really trying to understand the skills and abilities of individuals and looking at each individual's context and characteristic. I think oftentimes, and we're going to talk about this later, we assume things about people and their understanding about their illness and how to manage their illness, etc., and really kind of recognizing that that may vary from context and, and sort of the personality and characteristics of individuals. The other core concept is really understanding the environmental and social factors that lead to people not being able to have a high level of health literacy and what those factors are. We're going to talk a bit more about that later. And also the demands and burdens that are placed on individuals that will also then affect their health literacy. The ones that are in the box are really the most significant for us, for health professionals, and this also then outlines the expectations for service providers and the kind of responsibility that the sector has to really understand our clients and our patients, and understanding that diversity in backgrounds, but also context about the specific health issue. Really understanding what it's like for the patients and their experience. In terms of individual health literacy, making sure that they have the knowledge, the motivation, and the competency. And the competency is not only just about, understanding their health, but also navigating the system. And then, of course, last but not least is the organizational health literacy, and which basically means that all these the policy has to sort of be embedded in the organization. They have to have health literacy can't happen in a vacuum. It has to be supported by policies and processes holistically, so that the health literacy work is sustainable. Otherwise, it will collapse. The Department of Health in Victoria is also is quite heavily committed to health literacy. They also feel that healthcare providers in the health system should provide information and improve interaction with individuals, communities, and each other to respond to and improve health literacy. So again, it's talking about not just working with the consumers, but working within the health sector to see how we can improve this. And more you can see that this is no longer something that's optional. Health literacy is really becoming a necessity in how we understand health. Also just wanted to share with you what's happening in the diabetes space. The National Diabetes Support Scheme and the Australian Diabetes Educators Association has recently developed a document that I'm sure is now ready for sort of distribution. I think it is available on the ADEA website, but Tony can sort of further clarify that. But there are two really fantastic documents that they have just released, which the first one is called Improving Health Literacy for People with Diabetes. And this information sheet is it's a great document that provides practice recommendations to diabetes educators to better support health literacy for people with diabetes. So this is really quite relevant to your practice. The other document is a client-centered care for people with diabetes, and this provides health practitioners with sort of general principles and recommendations to optimize education, support, and care to people in their practice. So I would really recommend having a look at both of these documents. All right, so let's have a look at why this is so important, and the commitment to health literacy is quite timely because the statistics are quite striking. So the ABS has said that 59% of Australians are functionally health illiterate, and of the 59%, 75%, so an overwhelming majority, are born in a non-English speaking country. Now this is obviously a very striking statistic. And again, just to clarify that this is not a reflection of illiterate, like just basic literacy. This is health literacy. And this is not just focused on specific migrant refugee communities or anything. This is population-wide statistic. It really sort of makes us look at sort of our understanding of who is health literate, and perhaps we need to kind of revisit how sort of the assumptions that health providers are making in terms of how people are understanding health information. I think there has to be a huge shift that goes from the client to the sector. Oftentimes we are riddled with jargon, and it can be difficult to navigate. And also then looking at how do we then check in with that understanding and make sure that our clients are understanding the health information that we're giving. And we're going to be talking a bit about that later, where I'm going to be sharing with you some specific tools that to sort of consider.
Excuse me, Ambreen, sorry to interrupt.
Yep.
There are a few feedback saying that there is a little bit noise from the pre-sync. So any chance you can move your microphone away a bit further from yourself?
Is this better? Is this better?
Probably closer.
Is this better?
Yeah,
Okay.
I think that will do for now. Sorry to
Oh,
interrupt.
was there a feedback? That's okay.
Great, thank you.
Thanks for letting me know, V.
No worries.
All right. So what are we looking for when we can see that there are low levels of health literacy? And some of you may have already experienced this in your practice. So there's usually a non-compliance with the treatment regime. There's often a reoccurrence of the same condition. There can be an overuse, underuse, and misuse of the healthcare system. Oftentimes there's an overrepresentation of vulnerable populations in acute care facilities. They're managing the medication poorly, and oftentimes have difficulty making informed health decisions. And again, these might be ringing some bells for you. What exactly is the impact of low health literacy? So this is there's an increased risk of hospitalization and emergency visits when somebody doesn't understand their health sort of issue properly. Poor access and utilization of health services. There's also poor self-reported health status, poor compliance with medication management and immunizations, and increased risk of taking medication inappropriately. And also, needless to say, that this also has huge additional and avoidable burden on our services and especially acute services and our health funding. So health literacy really is, quite important and sort of relevant. Who are most affected? So this list may not come as a complete surprise, but community and linguistically diverse communities, culturally and linguistically diverse communities, excuse me, are obviously front and center of those who have low health literacy, because if we're thinking about accessing, understanding, and using information, there are multiple barriers at every level. A lot of migrant and refugee communities may have come from places where there were no sophisticated health systems. And so in order to access, there might be a number of barriers that are related to just, what they're used to, as well as, gender barriers, cultural barriers, and of course, language barriers. So that really then affects how able they are to access, understand, and use the health system. Older individuals, so this is also sort of self-explanatory, but a lot of older individuals are used to a very different health environment, oftentimes relying on maybe their children or sort of other people to accompany them to navigate the health system and sort of understand health issues in the way that is useful for them, because the health culture has changed, the sector's culture has changed. Same with disadvantaged populations. Access might be an issue for them, and which then obviously limits the health information that they're receiving, and also the health services that they're able to receive. And then individuals who have limited experience interacting with the healthcare system. This can affect anybody. You really basically, until you've been through something, you have no idea how it works. And so this is really, again, coming back to the context specific, that, somebody might be very comfortable, navigating the health system for a particular issue. However, when they're placed in a new situation, they might not be in that same position. Now, I just want to spend a bit of time looking at the factors that affect health literacy. And these are obviously sort of applicable to anyone, and especially the groups that I've just mentioned. So the first one is different health beliefs about the cause and the treatment of illness. This is something that is quite major. I'm sure that some of you have encountered patients who have a very different approach to explaining diabetes or their understanding of diabetes. A lot of them might think, well, I'm not eating sugar, so I don't understand how that should be affecting my blood glucose levels, or that they're managing them in different ways, and it's really worth understanding what the belief is, and so that you can work with sort of managing or negotiating those health beliefs, because it affects everything from how they view the illness, how well they're going to manage it in the future as well. Another factor that affects health literacy is the content knowledge of health issues. So while somebody might understand a particular aspect of their health, they really might not understand sort of the more intricate details of how their body works and their health, how all of that is supposed to, how it's all connected, and what is actually happening to them. Content knowledge of the health system, so who can they talk to, where do they actually go for particular tests or particular, various different agencies have different systems. So this is also something that affects health literacy. And then also knowledge of the words about your body and health and different types of illnesses. A lot of cultures may not have the same kind of information given in the same style and with the same words and the same understanding. And this is where the use of interpreters also becomes extremely vital in order to sort of assist with that knowledge and understanding. Of course, then that brings us also to language barriers that can be a huge part of a huge factor that affects health literacy. And we're going to look at this more a little later in terms of also the kind of material that we provide, the written material that we provide to our clients and patients. And then, of course, overall literacy levels. So, and that basically health literacy builds on basic literacy skills. So this will definitely affect their understanding of their health issues and their ability to manage. So just if you could have a look at this quote. This is by Doak and Doak, who are also quite sort of major leaders in the health literacy space. And the quote basically says, they have no visible signs of literacy disability. You cannot identify them by appearance or casual conversation. They may be poor or affluent, native-born or immigrant, and are found everywhere. Healthcare providers treat them by the tens of thousands. So this is really kind of looking at that, health literacy does affect some people, but really we can't know for sure, who has low levels of health literacy. And, sort of measuring health literacy also has not reached to a certain level that we can actually use a foolproof system of measuring health literacy. There are people, obviously, in the health literacy space that are trying to work that out. However, it's going to take some time before they can really zone in on the various levels of health literacy and really how that applies across cultures as well. So what I'd like to do now is move towards what this means in our practice, and I want to talk a bit about the clinical encounter. So there's some assumptions that are made in the clinical encounter that occur in the clinical encounter, and there are a number of interrelated factors that impact the encounter between you and your patient. And, naturally, we bring our experiences and our preconceptions with us to each communication exchange that we have. And it's really about stepping back and looking at what are those assumptions and how is that affecting also the work that we do. We all have our own cultural beliefs and our own values and our own worldviews, and of course our patient is bringing the same. Also, we need to have an understanding of the differences in socioeconomic, political, and cultural backgrounds. Our sort of backgrounds might be completely different to the backgrounds of our patients, and it's important to realize how that could maybe either clash or not be on the same wavelength. And also our experience of health and human services. There are a lot of people that, we might feel comfortable negotiating, and the system might seem simple or clear to us. However, that might not be the experience of the person who has come to see you. So what do we do then? What does that mean for us? And what we say is really to exercise universal precaution. And of course, everybody probably knows universal precaution in terms of infection and minimizing infection. But it's really taking specific actions to minimize the risk when you don't know how much information somebody has, or how much, what their level of health literacy is about your particular health issue, in your case diabetes. So really we want to avoid making assumptions and make the same information accessible for everyone. So not just assuming that, well, this person, has come in for this long, and so I'm sure that they know how to manage this illness. But it really is not the case. We had a recent, in one of the workshops that I was conducting recently, we had a participant who was a PhD, and when the doctor saw that she had a sort of doctor before her name, he got very sort of excited and sort of skimmed over a lot of the health information that he was giving her. And she, in future reference, said that she's not going to add that in front of her name because she felt like he already had made a lot of assumptions about how much she would know, and then that really then affects the encounter between the client and the patient and the service provider. So there are a few health literacy principles that then I would like to share with you today that can make that clinical encounter, that can improve the clinical encounter. And the first one we look at is with verbal communication. If the aim for us in terms of health literacy is for the client-patient to source, understand, and use health information, then there are these 4 very critical things that we need to be doing. And they don't happen sort of in succession. They can all happen at the same time. So the first one is obviously understanding your client. And this might seem extremely obvious. However, we really need to have an understanding of their health beliefs, their existing knowledge, their experience about, of navigating the system, of the general health system, and also their language services. Also accessing language services and whether or not they will need the use of an interpreter or specific information in a different language. So really trying to understand what their context is. The next one is check clients' understanding. I'm sure that a lot of us are doing this as well. However, oftentimes we do hear people, sort of clinicians, using, do you understand, is that clear, sort of words, questions asking, and oftentimes the patients are like, yes, because they're embarrassed to admit that they don't understand, or they don't want to waste your time, or they don't want to ask you to repeat something. So, all of this is really quite critical, and I'm actually going to be sharing a very useful tool in terms of that will help you to check your client's understanding in a way that ensures, are they actually understanding what we want, the critical information we want them to know. The next one is to encourage dialogue, and this is encouraging patients to ask questions, and also having strategies and systems in place where they can do that, where where there is a two-way dialogue that can occur. And the last one, and of course definitely not the least, and it basically is cross-cutting throughout your whole communication and your clinical encounter, is building rapport and self-efficacy, because this really then improves the ability for dialogue. They will feel much more comfortable in asking you questions, much more able to sort of feel less pressured and share more about how much they do know and what kind of information they still need. And when we talk about building self-efficacy, this really means that so self-efficacy in this context is really the patient's belief in their capacity or confidence in the ability to have control over your own motivation and your behavior. So this is something that is quite critical, and I'm sure a lot of you are already using the skills and the tools that you feel like empower the client to sort of take charge and manage diabetes. However, this just sort of reinforces that. All right, so just going to the tool that I had mentioned earlier. I'm sure some of you, in fact most of you, have probably heard of the teach-back technique. You might call it something else, maybe talk-back. This is also similar to show me, the show me technique. However, when we want to understand our clients, oftentimes, again, we do ask sort of closed-ended questions, and that, obviously we have sort of the best intentions with, but we may not actually be understanding them in the way that we should, so that we know what kind of information to give. So the teach-back technique is an effective method for ensuring that patients understand what you've told them. And it involves asking patients to explain or demonstrate what you have just been discussing in your clinical encounter. And it really follows 3 basic steps. So step 1 is basically the clinician is explaining a new concept or a diagnosis or a treatment plan to the patient. Step 2 is where the clinician is now then assessing recall, patient's recall and understanding. But the difference now is that instead of us putting pressure or putting the responsibility onto the client for the understanding, we're really sort of taking that back and saying that I want to be sure that I've explained your medication or the situation or this particular aspect properly. Can you tell me, how you're going to take this medicine? Or can you tell me how you're going to use your blood glucose monitor? Or can you show me? Can you tell me what are the kind of foods that you should be avoiding? What are the kind of foods that are good for you? And then the patient explains back what was said. However, the trick is really to ensure that the patient does not feel tested. So it's not really, this is not a test. We're not sort of checking how well you've been listening to me. It's really about recognizing that you have explained it in a way that they have understood it. And so if the patient can't demonstrate that he or she has understood, then the clinician goes back to step 2, step 1 and step 2, and sort of then rechecks the understanding. And if that has been understood, then the clinician can introduce a new concept and then follow the same steps. And the idea is really to use, not to use a lot of information at the same time. So introduce one particular concept at one concept at a time, really using simple words, plain English, and also slowing down that communication so that the patient can understand that. And this seems like a very simple technique, but it can really open up a lot of areas of sort of, an exchange in terms of that understanding. Recently, I did some work on hepatitis B and sort of made a helped design a video on teach-back, and a lot of the experts that were talking about their experiences of using teach-back was quite astounding. One particular expert expert in the sort of infectious diseases and Hep B space had said that she had a client that had been coming to her for about a year, or coming into the clinic for about a year, and when she was able to see him, she just wanted to check his general understanding, and he had said that he thought that Hep B was sort of a death sentence and that he was going to die. And for somebody who's been living with that for about a year, and how that affects social relationships and how that affects, his adherence and understanding and everything, she was just really quite surprised that nobody had really checked what his understanding of the illness was. So teach-back can be sort of quite a powerful tool for you to utilize. The other health literacy, sort of principle of health literacy that we want to look at closely is not just verbal communication, but written communication. I think that there's so much written material in the health sector, and oftentimes, it is, of course, important, but there is also an over-reliance on material. And when we talk about written communication, it's more than just how material is presented, but it's really understanding, your audience and making sure that that information is easy to understand. So the first health literacy principle that we talk about is using plain language. And this might seem simple. However, there are a lot of times where the information that is given to clients is extremely, is very much from a clinician's perspective, using words and language that, service providers and clinicians might use because we're used to it. We're desensitized to it to an extent, and it might not be as clear to the other person. So also how the information is organized, so that your information has a logical organization in whatever information, written information that you're giving, using you and other pronouns rather than talking about something generally, using the active voice, using short sentences, and all of this might seem sort of very basic, but there's a lot of information out there that really doesn't follow these sort of principles, and it can really then affect how people are then using that information and understanding. Oftentimes when we walk into clinics, there's so many posters and so much information, and with photos and unpleasant looking photos and things like that. And oftentimes we're not testing how that information is actually being received. Recently, in one of our health literacy courses, somebody had designed an oral health sort of a brochure that was talking about gum disease, and the photos in it was just, they weren't, nobody's would want to open that up and have a look at that. So it's really looking at what we're actually, how useful is the material that it might be useful for us, or we think that it's getting the information across, but it really might not be. The next thing to look for is readability, and basically readability is when we talk about readability, it's usually at so there's basically a debate going on. Some people say that it should be at the level of a grade 7 and 8. Some people, CEH believes that it should be lower than that it should be at level grade 5, for example, which is also the level that the Herald Sun uses. And really, it would depend on the particular community, on the particular clients, their understanding. And the only way that you can really test that, really be sure, is by testing it, with the community that you're actually working with, and seeing is this language too difficult to understand. The good thing is there are now online tools that will assess to see how readable a certain material is. And these, even Microsoft Word has a tool, online tools that you can very easily access that will give you a really good idea of what level and sort of various other things that will affect how well you will be able to communicate something in a written way. And also, other things like line spacing, how many white spaces there are in your material, is there too much information, are we using really long sentences, and what kind of photos are we giving? Are they relevant? Are they easy to look at? Are they, culturally appropriate? So all of these things are extremely important. And then also looking at glossary of common terms. Again, as mentioned before, we use a lot of words that we have been desensitized to that are natural for us. However, it's important to use common language and avoid jargon. And there's actually now a tool that you can use called PlainMed that really sort of uses and sort of deconstructs the jargon, and is very useful for clinicians who really kind of want to simplify the language. And so now it's also available on your smartphone, so you can use it outside the clinic as well. And there's an app available, and I would really encourage you to sort of look at that and see how terms that we very commonly use can be simplified. So now, sort of looking at the verbal and the written communication that we've talked about, and linking it to what I previously said about the clinicians can be doing this in their sort of in their practice. However, we really need the organization to support that practice and embed health literacy principles throughout. So one really good way is to embed this in your policy. And every organization has a communications policy or a branding policy. And really, getting health literacy principles as part of that policy would be a fabulous way to roll that out and to ensure that all the material that's going through the system that you are creating really goes through these different levels, looking for sort of making sure the health literacy principles are being followed. And then when we think about what a health literate organization would look like, so now moving sort of to the bigger picture, it's basically an organization that makes it easier for people to navigate, understand, and use information and services to take care of their health. So it's not just about, how well the practitioner is sort of how good they are in terms of their verbal and the kind of communication that they're giving, but also the work in that approach won't be sustainable if we don't have those systems in place. And every level of management, all the people on board in terms of whether it's admin or HR or even, the practitioners, they really need to be on board about what health literacy is and how that impacts our clients and value it and value that sort of health literacy principles in order for that to be sustainable. I also want to share with you something that is now emerging, the emerging framework in the health literacy space. And this is really including health literacy, cultural competence, and consumer participation, and looking at how these three things intersect and how really one is incomplete without the other two. So, just to, I don't want to, I can't, I could actually talk a bit more about this, but just in the interest of the presentation today, I wanted to just sort of flag it and get you thinking a little bit about how these three intersect. Unfortunately, won't be able to explore it in depth. But there has been a recent shift in a lot of the work that is being done that uses these three things together. And when we talk about cultural competence, it's really not about understanding a specific community or knowing that community, because really, that's sort of we can't really expect to know everything about a particular community. But it's really saying that it's about having the right systems in place to make sure that we can work cross-culturally with any community. So what are the cultural, what sort of competencies do we have that we are ready to sort of cater to any particular community that comes to us? And it's really more about the system level and how ready the system and the organization is, rather than just on a sort of practice or clinical level. And consumer participation, there's an increasing push towards having a patient-provider partnership, but also having partnership with communities, so that you're making sure that the material and the information is being given in a way that that they can access your service and it's relevant and they're able to use that information. So really, you can't have one without the other. In order to have health literacy, you need to have participation from your consumers to understand their health beliefs and what's actually happening in the current understanding, as well as then being able to respond to the needs of that particular culture, which then brings in the cultural competence aspect. And it really would make a difference, and it becomes quite effective in using when you start thinking in terms of this framework. I know that in the health literacy course that we've done this year, we're running 3, and it's a course that runs over about 8 months. And in the past and in the current course, we've had quite a few participants from Diabetes Australia, Victoria, and it's amazing how they have really taken this on board and are catering their services and their information, particular for the indigenous community, looking at different pictorial guides for various ethnic communities, and looking for readability and relevance, and hopefully that will definitely improve the sort of interaction that they're having with their clients. Just to kind of demonstrate what I've been talking about in terms of health literacy principles and how these are embedded, CEH recently, sort of in actually maybe a few years ago, did a campaign for the Department of Justice on gambling. And obviously this is something that's very different to sort of diabetes, but the example is very effective in sort of honing in the health literacy principles that we've been talking about. So obviously gambling is you know, legal and it's a state-sponsored sort of thing, but we can't. But what really becomes an issue is problem gambling. And the Department of Justice had sort of rolled out a campaign for various ethnic communities, and they weren't really getting the response that they had desired. And so they had asked CEH to design a campaign in order to really get sort of the message out there about the Gamblers Help Hotline. And so what CEH did was it basically looked at it again from the health literacy, cultural competence, and consumer participation point of view, and really sort of worked with each community in understanding what meaning does this have for their community. Because the demographic is completely would be different for different communities. You know, the impact would be completely different for different communities, and you know how they and sort of their understanding of it. So just to give you an example, this first one was with the Iraqi community, for the Iraqi community, and it gives you an idea of the demographic and also the colors that were used. You might not sort of see two men in mainstream Australian culture walking like that with each other. So this was really sort of tested out with sort of Iraqi community, and you know, they had agreed that this would be relevant. So this one was with the Ethiopian community, and this is quite interesting because these two men are actually community leaders who volunteered to be in the ad to sort of make it okay that, you know, to acknowledge that gambling was an issue for their community, or and to sort of come out and you know, seek help if there was a problem. And for them, you know, especially for the Islamic community where gambling is forbidden, this was something that was really seen as threatening their faith, and also, you know, so they felt that really highlighting that aspect of how it can affect your family and your faith was an important message to include in their poster. This one was for the students from sort of an Indian background, and they had developed two, because the first one that they had developed in English, they didn't want it to seem that it was just, you know, a general poster that had been developed using somebody from an Indian background or Australian Indian background. So they also designed a poster in Hindi. So it was very targeted to international students who might be gambling, and getting that sort of information across to them about seeking help. This was for the Chinese community, and then there was a poster that was in traditional Chinese, and basically they found that a lot of the hospitality workers that, you know, were involved who would gamble, and so this was something that was targeting them specifically. This was for the Eritrean community. And this, as you can see, their message was a highly emotive message and a highly emotive visual, which we're not sure that it would probably be used for a mainstream kind of audience. I think the Department of Justice was a bit sort of apprehensive about using this kind of visual. However, the community really felt like this is what it was like, and this is what the impact was, and that this kind of pictorial and this message was what was really going to get people to listen and seek help. So what we're really trying to say that you know, a particular health issue needs to be addressed differently with different people, and in your practice that needs to be you know, sort of considered, and there's a very different meaning and very different lifestyle and very different health beliefs that we will have to negotiate and cater to, and it's really about then understanding your client and seeing where they are in that space, and then catering and sort of tailoring your response to that need. So as a clinician, what are we saying? That again, just to reiterate and summarize, because we're now at the end of our presentation, is really content and context specific. So because one person can navigate the health system in one way, doesn't necessarily mean that they will be able to navigate it or understand health information across the board. And it's really about that individual's context, and we really have to take that into account, exercising universal precaution. Also, the second one is the capacity to change your practice, and so really having that the ability to practice the tools and to encourage dialogue and engage your clients in a way that really promotes that understanding and improves that health and contributes to their improved health literacy. And thirdly, having the capacity to change the organization, and this is obviously not something easy, but starting slowly and seeing how policies can be embedded within your current system, so that not all the pressure is on the clinician or the client, but really that the organization as a whole supports the workers and can facilitate that best health literacy practice. Okay, so that sort of brings us to the end of the health literacy, the introduction to health literacy. I did want to share some resources with you. First of all, just wanted to share what CEH the kind of support CEH can provide, and that's really, as I mentioned before, about our library. There's a lot of information that you can access. Also on our website, we have a lot of resources on there about language services, about health literacy. That Teachback tip sheet is on there, which you can sort of access and download, which also then outlines the steps that you can use. There's a host of information on there. So please, I would really encourage you to check that out. As well as the trainings that we provide. If you are interested in sort of deepening your knowledge about health literacy, we offer a health literacy course, which basically 4 full-day courses, full-day sessions over 8 months, which include 2 projects that you sort of carry out within your organization, so that really starts you to think about how health literacy can be institutionalized. And then we also offer a 1-day intensive health literacy course for those who aren't able to maybe have an interest but can't have the 8-month commitment. We also have a Foundations of Culturally Competent Practice training that we conduct. We also do a Negotiating Between Health Beliefs training, which is extremely useful. How do you actually negotiate when a client comes to you and their understanding or where they're coming from is vastly different. And then, of course, also looking at organizational health literacy. So as an organization, as a manager, as an executive of the organization, how do we then start to think about this and institutionalize this? And we also offer trainings on working with interpreters and much more in-depth language services training that could be useful. I've also included sort of 2 slides of online resources that you can refer to when in terms of getting more health literacy information. And I've also forwarded this to Tony, who can then share it with you and sort of email it to you and give you a hard copy of this resource list. And that brings us to the end. Thank you very much for your participation. And if you have any other questions and comments that you are not able to sort of write in today, please feel free to contact me or the organization for more information. Thank you.
Thanks, Ambreen, for such a very informative presentation. And it obviously gives us more understanding on such an important topics. And during the presentations, there are a few feedbacks came through, so I'll just push them through to you over the last 5 minutes of the session, if that's okay. So there is a feedback that health literacy, which include informed consent, can be difficult in people with diabetes and disabilities, so not just those with lower literacy skills. Providing alternative materials to discuss health issues and alternative methods to get understanding from the patient can be done, it shouldn't just be assumed that they cannot give informed consent or understand the condition. So the person who sent through the question as a hospital nurse working in an acute area such as operating theaters, they often get patients arriving at the theater doors who have been told that they are having this operation but really don't know why or what's it all about or what is going to happen. So do you have any insight to share, and also do you know of any information or training relating to this in this as well?
In terms of informed consent, that's actually extremely important, but I would then sort of again go back to the system and the structure of, you know, what kind of information has been given to the client about the procedure and the process, so that when they get to the stage of the actual, surgical procedure, that they have understood. So I think, you know, the only information we can also provide to you is really looking at health literacy and more in depth and seeing, you know, where are the gaps, what's happening, you know, at which level is that information not being given.
Great, thank you for that. And also another question is about PlanMed. A few of our participants actually went to the Apple App Store to search for it, and it doesn't seem to be an iPhone app. Do you know if there is any other similar app provided on Apple Store?
I'll have to look into that, actually. If yeah.
No worries, and then I'll be more than happy to send it across to our participant today.
Sure.
And also finally, do you have any specific tools that we can use to measure whether our written materials are more likely to meet lower literacy levels?
Yeah, so there are a few online tools that you can use, even if there are a number of them if you just Google online readability tools. So like, as I mentioned, also Microsoft has its own readability tool, but you know, you can really look at, and these readability tools will give you the level, so what grade that, you know, it's usually at. So let's say if you're looking at, if you enter some information and it's at level 10, then you can sort of look at the material that you presented and then repaste it and see then, you know, what sort of level it's at. But I would encourage that, you know, you really can't be sure until you test that with your client as well. It might say that, you know, level 7, 8, you might be using level 7, 8, but then when you actually use that with your clients or when you are testing it, it still might be, the information might be too difficult to understand. So, you know, definitely use the tool as a guide. However, we would still encourage to have that consumer participation element in there.
Great, thank you for the insight. And there is one last final question just coming through, and it reflects the stats that you just presented on 59% of the consumer are health illiterate and 75% born in non-English speaking countries. So given that those stats was given in 2006, do you think these number are still the same for 2017, 2015?
Well, unfortunately, we don't have more recent information that is used sort of as broadly as the ABS does. But I mean, we can only sort of guess how much that has changed. You know, till now, the number could considerably be higher. However, if we do have that information, I can definitely share that with you. But this is sort of last kind of broad level study that the ABS has conducted and the information that we have.
Great. Great. Thank you so much. That's the last questions just came through from our questions panels. Unless if the current participants has any other unanswered questions. I saw Alison White just raise her hand. Oh, no worries, sorry. I guess that's conclude the section today. Thank you everyone for participating, and please, after the sections, just follow the link on the screen now to complete the participant survey. We will send this to you as well in the follow-up emails, and we'll be in touch after sections. Thank you for your time, Ambreen.
Thank you. Thank you, everybody, and Tony and V. Thanks a lot.
Great. Great. Have a good one, everyone.
Bye-bye.